out for many of the surgeons and I think to many of you guys. I have a few disclaimers. So I am not a surgeon, unlike many of you distinguished guests. I actually am an emergency physician, but I also work in the tech office. So this is rather strange for me in terms of not being able to solve my own tech problems. I work with the Holomedicine team, and I think I'll just share a bit more about what we've been doing in Singapore and hopefully with collaborations with other parts of the world. So a few disclaimers, all work presented today represents actually research and development and work in progress, and all the studies that we've been doing has been conducted under approved ethical standards with relevant review boards. So first, what is holomedicine? Because I think this is a new concept that I think many of you might not have heard of before. So we're sharing a bit more about our journey as a hospital in NUHS in Singapore and how we actually started this journey. So holomedicine actually originates from this device called the HoloLens from Microsoft. I think HoloLens has been in the market. I think many people are now a lot more familiar with Apple Vision Pro and its huge launch, but it's not exactly the first device in the market. I think Meta had their own Meta Quest. Together with HoloLens, we are actually been working with HoloLens 2. So it all started when Microsoft actually organized a half-day workshop in Microsoft as well as NUHS. I think what we did was from the iteration process worked with the developers and software engineers and of course clinicians and surgeons to understand what are the challenges, what are the use case, and what possibilities can we use to help surgeons better their clinical practice. And I think that is actually the main point of our practice. We leverage on this technology called mixed reality. So I think many people are very familiar with augmented reality as well as virtual reality. In virtual reality, you wear the headset and you're completely immersed into the environment that is virtual in space. While augmented reality is actually just overlaying similar to a heads-up display, showing you little points of information on your headset. While mixed reality actually involves a lot of different cameras that tracks the surrounding that you have and basically uses that location to kind of overlay holograms to assist you with whatever you're planning to do. We hope to use this technology to help enhance the clinical capabilities, improve the clinical experience, and also help in the future improve patient outcomes. So our program approach is a lot of R&D and actually building up the software for this device. So just from Microsoft's standpoint, the HoloLens 2 is not a medical device, but the thing is we have been building a lot of software together with startups in Germany to actually help enhance this experience. So I'm going to share a bit more on the first video is actually done by our director, who is a HPB surgeon in Singapore. This is actually utilizing the hologram of his preoperative patient. This is actually a hologram that was generated to help him with his surgical planning. Basically, it marks out both the liver parenchyma as well as all the vessels, as well as the bile ducts for the liver itself. This helps the surgeon with the surgical planning on where his resection is going to be, what vessels he's going to encounter, and basically where the tumor is and where the locations is to ensure good margins. So as you can see, this is actually tracking all around. Basically, it's actually still interacting with the environment itself. So he still has a perfect view of the conference room where all this surgical planning is being taking place. So I think I met a lot of neurosurgeons as well as cardiothoracic surgeons in the last couple of days, and it's been amazing to hear their stories and experience. So this is us actually using it for a case itself for neurosurgery during the actual surgery itself. We took the MRI image of the patient during for the surgery itself and overlaid it during the surgery. As you can see, the surgeon has his gloves, so he does not need to scrub out while using this device. He can overlay the MRI image directly onto the patient itself and basically have visualization of the key structures he's going to fix. So I do have the device with me, so if anyone is keen to try, because videos tell just part of the story, but I think actually having the experience to try and interact with the holograms itself is just a different experience altogether. Okay, so I think many of you are minimally invasive surgeons and laparoscopic surgeons, so we have actually also utilized this for laparoscopic surgery. Because it is a device itself, we can actually stream the feed that you're going to face in your laparoscopic surgery onto the HoloLens itself, and have you also interact with the holograms itself during the surgery. So as you can see, this is my director doing the surgery itself. So I think a lot of it is being driven by the clinician, not from software engineers just building programs that they think what surgeon would like, but actually a close collaboration between clinician and the software engineering side. So I think that's actually where I'm working quite closely between the engineering department and the surgical department. So this is actually a planning for graft surgery. I think a common challenge among transplant surgeons, especially liver transplant surgeons, is for the pediatric population. I think biliary atresia is a big challenge for many clinicians in Singapore as well. And of course, most of the transplantations usually occur from the parent cell. So I think the graft size mismatch has been quite a common problem. So we helped actually overcome many of these challenges by actually taking the CT scan of the patient, of the baby itself, and then also of the graft size that we hope to get from the parent, and utilize this to kind of overlay directly whether we need to do any graft reduction for the patient itself. So this is during the surgery itself. It helped the clinician actually estimate the graft size that needs to be harvested from the patient's parents, and then after that to be brought over for the child transplantation. We have utilized this for cardiothoracic surgery for minimally invasive coronary artery bypass. I think the main concern with minimally invasive coronary artery bypass is actually the access itself, because I think the moment you have bad access, it makes this surgery a lot more challenging compared to normal. So I think the surgeon here is able to actually overlay the holographic representation of the ribs as well as the heart over the patient's body, and it helps actually guide where the incision site should be. We have also utilized this for different protocols for ourselves for broken ribs, because you can basically overlay the CT scan directly on the patient. You know where your access is. For rib lesions as well, for patients who are either obese or very muscular, there's a bit of challenge in palpating where exactly the rib spaces are or the rib locations are. That actually overlaying these holograms as ancillary tools actually do help the clinician quite a fair bit in actually reducing surgical time, because I think the typical procedure is doing a VATS prior and then localizing the lesion and then doing that surgical incision over. So I think this case was actually one of the most touching cases for our department, because this was actually very, very significant to a lot of us. This is a story of about a 28-year-old lady with pelvic paraganglioma. She had basically multiple recurrence onto her pelvis itself, and I think at the 28, 29-year-old, I think we approached many surgical oncologists and I spoke to many of them and asked them, okay, is there a solution for this case? Because there's 3 different lesions in the pelvis, and when, of course, during operating, everything is red. It can be visualized on the PET-CT, but everything is about 1 to 2 centimeters in size. I think we approached many different organizations, J&J, Medtronic, and any visualization tool that can actually kind of help with this surgery. But I think the overall arcing statement was this patient, this 28, 29-year-old lady, needed a THPSO with a bladder reconstruction. And I think that is very, very damning for someone so young, especially she still not having a family, not being married. So I think we, of course, approached her and said, this is, of course, all still experimental. We are still in the research phase of things. But there's a possibility that if we overlay your PET-CT during the surgery itself and do send for frozen section, we might be able to save all your reproductive as well as your urinary function after the surgery itself. So that's actually what we did. And of course, this is an alternative to completely removing your reproductive and urinary function. I think she agreed. We took the PET-CT and we overlaid it during the surgery itself. I think my director, together with the surgical oncologist, was working quite closely, and he he was identifying and overlaying the PET-CT. And then every location where the tumor was, we took about 1 centimeter margin around it. We sent it for frozen section. And I think we managed to get all the 5 different lesions that was noted on PET-CT. And I think that was actually one of the driving principles of why we do this, because it actually shows a change in outcomes and actually helps improve the life of our patients. Okay, so I think we have been speaking a lot about global health. I think the main thing that you actually really need to use with HoloLens is actually an internet connection. So we have been utilizing this. So this is actually a teleconsult or teleproctoring between a surgeon from Japan, a surgeon from Singapore, and Nepal. We've been using, this is actually a multidisciplinary tumor board meeting between many of these surgeons. And it can also be utilized during surgery because this is actually all done on Microsoft Teams because it's a Microsoft device. You can wear the headset, a surgeon from Singapore can see what the surgeon in Nepal is doing, kind of guide him during the process, especially if it's surgery that he's not familiar with or not done before. We can even bring up the holograms during the surgery, and annotations can be made from surgeons as far as United States. So it is actually cross-border. And the main requirement is first the device itself and internet connection. So since 2021, the numbers, okay, I should have updated it, it's about 150 surgeries with 9 different clinical departments, from cardiothoracic to urology to general surgery to neurosurgery, and we have kind of expanded our team where it initially started with my director, who is a HPV surgeon, and a software engineer, to 3 different data scientists, 2 software developers, network architect, as well as an implementational specialist. We have also engaged multiple universities across the world, in Germany, in UK, in Cambridge, on R&D projects, because we do want to work with different organizations and universities to kind of further validate the use of this, of Holomedicine itself. It uses the multiple different sensors to kind of like help. So it's like I said before, it's the concept of Internet of Things, and using all these different devices to feed the information back to the HoloLens, because it itself is a computer itself. We have expanded beyond surgery, not just to the surgical practice, but utilizing the different functionalities of HoloLens for point-of-care solutions. As you can see, there's many different cameras. Not only, I think there's about 6 different front-facing cameras, and also about 2 different cameras tracking your eyeballs to see where exactly is your line of sight. So the 2 capabilities we kind of utilize is for vein finding as well as for ultrasound itself. So because the HoloLens has an infrared camera to track exactly where has an infrared camera that tracks heat, the difference in wavelengths, and that's how it tracks his hand. We decided to utilize this and change the wavelengths it detects to kind of identify veins for patients. Because I think for oxygenated blood versus deoxygenated blood, it actually emits a different wavelength from your skin itself. So through this, we actually utilize this camera to kind of visualize all the different veins for a patient. And it's very important for me, who is an emergency physician, because I think when you have a difficulty in cannulating a difficult vein, actually this does actually offer a different perspective. So yeah, you have a different functionalities for hiding the vein, locking the box where you do want to see the veins. Yeah, so many of the different functionalities have been built in.
You can just summarize in 1 more minute.
Oh, okay, I'm so sorry. Okay, so I think the other interesting point is actually ultrasound itself. So we have been utilizing ultrasound to actually project ultrasound images directly into the patient's body. It helps with different procedures that you do. I think we've been utilizing it for thyroid, for FNAC, because it actually projects the image of the ultrasound directly into the patient's body, having direct visualization rather than looking at a different screen. So sorry, I know I'm the one holding you all through before lunch, so I'll try and summarize as much as possible. Yep, so we have also used it for rehab, for occupational therapists, for patients with stroke and difficulty with hemineglect. It actually help patients focus on different locations for the holograms itself to help train them overcome this hemineglect. So as you can see, HoloLens is not just a one device for one particular use case, like one particular surgery, but we're usually to expand through all different aspects of medicine. Yeah, so I think this is actually utilizing a digital twin, eventually utilizing, because that's the next step. All the holograms currently are being overlaid directly by the clinician during the surgery. We're hoping for real-time navigation where the hologram automatically locks on key landmark structures and just overlays the hologram directly on the patient itself. Many of this is still up on R&D, and I think this is how we are planning to do it with the 3D mesh that we've been working on. We have incorporated haptics for training, so that's one aspect. I do know I'm short in time, I'm so sorry. For education and training for residents itself, I think during COVID-19 there was actually a pandemic where many of the medical students were not allowed into the medical wards. We actually used the HoloLens to actually did Microsoft Teams with everyone to kind of have an understanding of how the ward rounds went and during the surgery itself. And of course, intraoperative factoring. We also have incorporated in patient counseling, allowing the patients to use the HoloLens itself to visualize what's going to be done for the surgery, and we do notice that they actually do appreciate this level of counseling. We have also engaged the medical school, teaching them different procedures like IDC insertions and venous cannulations, because we can build the training program onto the HoloLens itself to kind of allow the students to interact with these holograms and learn more from through this program. Yeah, so I think there's many hurdles and limitations. So I think, like I said, this is still in the research and development phase, and we're still working towards finding many partners and collaborations with different universities and different hospitals to kind of help the adoption of this. There is still further iterations of these mixed reality devices. This is still HoloLens 2. From what we hear, Microsoft is planning to release HoloLens 3 at the end of this year. And we will have to see and adapt what capabilities they do have. So our motto is the best way to predict the future is to create it, and we're always looking for people to create it with. And then this is the wonderful team that we have. Thank you.
Thank you, Dr. Yeo. Very good talk. We have one more talk before lunch at Dr. Sabha Ganai, who's the expert in surgical ethics, who's going to talk to us about the ethics of artificial intelligence in surgery. Thank you for joining us, Dr. Ganai.
Sorry, I'm giving you all an ethical dilemma here in terms of staying here versus lunch. I don't know if that's a conflict of interest or a conflict of commitment. I'm going to spend a moment to talk about disclosures. And this is actually an important piece because we all have biases. And as surgeons in the future, our biases will potentially be academic in nature. They will be sometimes will be owned by private equity or other influences. And in terms of my role as the chair of the AHPBA CUI committee, we took some time in terms of looking in white paper of specific use of AI. And I think one of the important things is to kind of moving forward a piece of, in terms of use, because it will be ubiquitous in terms of how we practice medicine and surgery, is having a reflection of transparency and disclosure. In terms of my roles, I am a surgical oncologist, I am an ethicist, but I do have an analog bias. I am a Gen Xer, and I am a reviewer for the NIH for a SBIR medical imaging study section. And this is a really important piece in terms of future use of AI and algorithms do need to be FDA approved. And it's important that we as surgeons are part of the teams and committees that are part of the review process. And one of the important pieces in terms of examination of many of these future algorithms are specific to methodology in the design of the algorithms, as well as biases that can be influenced by the patient populations that are being used and whether they are representative of the populations that we'll be treating in the future. So I'm going to kind of speed through this. This is actually a video on the right that was created using an AI software. That's a 2.5-minute video about autocorrect that the AI technology generated on itself. So I am a Gen Xer, and I grew up spending a lot of time enjoying books like the Road Atlas to kind of study in terms of how to get from place to place. Growing up in Southern California, pretty much everybody used Thomas Guide to be able to navigate the freeway system. And I think one of the important things are these books that we used to use are now obsolete because of technologies. In addition, how we curate music has completely changed. And this image is AI generated of Casey Kasem and mixtapes, but many of you may recall having created your own mixtapes and passed it off to your friends. And we don't do that anymore. And I think the way that we encounter music in itself is quite different, and maybe not as rich in its way, based on how technology now assists us. So this is a slide I actually use for educating students. It's actually part of the clerkship orientation for surgical residents or students. And these are the 5 virtues of thought as described by Aristotle. And really, during the first 1.5 to 2 years of medical school, the students are really just focusing on episteme, which is knowledge acquisition. And a lot of this has really transformed in the era of Google and how we, as a culture, are not reading or memorizing things the way that we used to, but learning in terms of more application of knowledge in different ways. The second phase really in terms of comes from techne, which is really critical as a surgeon, the whole thing in terms of skills acquisition. And this does not just apply to the technique or how to do a hand-sewn anastomosis, but can also be applied to how do you stabilize a critically ill patient. It's really how do you do a task. And that's really what the student and resident is doing during their first years of training, is really just kind of, in that sense, embracing that they're taking knowledge that they've acquired and now applying it to the management of patients. The concept of nous or comprehension really comes into play in terms of the process of informed consent. Because when you're talking to a patient and having them make a critical decision on moving forward of the decision, do I put myself through an operation, you're really having to educate them just enough knowledge for them to make a life-changing, transformative decision. The concept of Sophia really comes down to what you need to know to pass your surgical boards, and do you have enough wisdom gained through instruction. And then phronesis is what you deal with every week in M&M in terms of, have you gained wisdom through development? Are you making an optimal choice? And that's part of lifelong learning, really that process of getting better and challenging yourself and developing your skills. Now, all of these components of thought per Aristotle are really elements of intelligence. And when we talk about the concept of artificial intelligence, we're really talking about these models and systems and algorithms that are basically learning and simulating in that sense of, often a probabilistic way of what we would consider as a important piece of processing information. We're not there where we are in terms of our AI systems replicating human thought in all of these 5 domains. But in terms of the first 2 domains, in terms of knowledge acquisition and processing and then skills, we're getting there in many elements. For time constraints, I'm not going to go into too much depth on this slide, but it's actually an important paper authored by Andy Gums, who's now in Europe. But he's an HPV surgeon, and part of this paper actually defines artificial intelligence in surgery and autonomous actions of creating that there are 6 levels of autonomous actions in surgery, where the level 5 type device would be something where the processing of whatever technology is able to completely process autonomously. We're currently at level 3 devices right now, with in the OR, even if you do use a ligature, that feedback loop that happens with impedance and measurement, where you as a surgeon just respond to the beep or the ding and complete the process of sealing a tissue and cutting. That's a level 3 device. So we're already beginning to go through the different levels of autonomous actions in the surgical realm. And it may take some time, but we're currently in an arena of self-driving cars, and perhaps we will soon be seeing things that are learned particularly from the robotic technologies that we're using, where video is recorded and further learning can happen from past mistakes as well as successes, can help avoid problematic issues, or can help kind of automate certain elements of the operation. So in terms of when we talk about some of the critical pieces in the use of artificial intelligence, these areas include transparency, credibility, auditability, reliability, and recoverability. I'm going to go through a couple of these in the next few slides. So the first area that I want to kind of discuss is related to autonomy, and it's not simply from a patient autonomy perspective. It's really in terms of the concept of the user and ability to also democratize use of the system. And there are many benefits that have already been discussed by the prior speakers in terms of benefits of the AI tools, because you may be able to create something that was very complex and be able to simplify it in a way that surgeons in less resourced regions can then take on and do those types of techniques, or perhaps with greater safety and greater precision. It could, these tools may improve clinical capacity. And we've heard a little bit about chatbots. There's a lot of talk about using those to automate the communication between patients and healthcare teams to make sure that people are using clinical workflows and pathways and following guidelines. And then these AI tools may decrease the need for experts to improve repetitive tasks. So if we could automate documentation in a way that effectively creates a pathway for billing as well as coding, that would actually really help from a lot of different levels in the healthcare system. Some of the challenges here, though, in terms of these the limitations of these tools, is that you do need subject matter expertise to confirm or validate context. Even if you're using something that's a speech transcription for your documentation, you may still have to go back and just confirm, or and that could still take you some time out of the system. But you may have to also just make sure that the context is also proper, because as we know, the way that we speak and even regional variations in language and colloquialisms, those can also be captured improperly. There should be governance in place to protect patient privacy and rights to data use. And this is an important piece that is going, actually, in terms of the EU, they've put some policy changes, and in the US, they're looking at greater oversight in this piece. But the whole thing in terms of if a patient has the right to opt out is still a little bit unclear in terms of data sharing for future use. In addition, whatever we're talking about in terms of whether it be a technology or a platform, you have to have some trust by the user that it's safe. Otherwise, you're not going to have people participating.
One more minute.
Okay. So in terms of explainability, this is a huge piece, but I'm going to just talk about the risks. The challenge here is that the algorithms, sometimes based on their design, may not be transparent. So we may not actually understand how the algorithm through a complex neural network has been developed. And that piece, people are currently trying to figure out ways to reverse engineer that explainability, but that's going to be an area in the future. And then in terms of the whole thing about quality control, you really have to be using clean data, and it's really challenging because your data sets are not often annotated, so you may not know objective features that you can look and connect to outcomes or ground truth, so that you can have good predictions. And that's a piece that's going to be hard in the healthcare arena, because it takes a lot of manpower to annotate data so that it's usable. And then in terms of the justice and equity piece, the problem of addressing bias is real, and because there's already been systemic discrimination at the underlying aspect of most of our societies, we actually have to have ways to address that through the use of data. In terms of the concept of some of these algorithms may be able to, for example, if you're able to control for race or ethnicity and gender, they may still capture that through zip code or other kinds of features within the data set, whether type of insurance, and that may still protect certain people more than others. In terms of credit score might actually become an important piece in terms of a decision-making tool, and you may not actually want that to be part of your algorithm. And the whole thing about design by diverse teams certainly is something that needs to be continued to look at. This is a book, if you're not aware of Nate Silver, he became pretty popular after Moneyball and predicting the Obama election. But he, in his book, discusses the ability to make good predictions requires an understanding of three things. One, the accuracy of the forecast. And in doing that, you always should be providing a level of error to any prediction you give. So you always give error bars whenever possible, or an understanding of how uncertain you are. And we don't always do that when we provide predictions or prognostication. The other is having intellectual and honesty about your prediction, and that's really an understanding of the bias that you're bringing into the discussion. And then the third is always be aware of the value of your forecast. And this really, in terms of when you're providing information from a prediction, you really have to be able to understand the concepts in terms of risks and benefits of that. And then also kind of have a conception based on the data that the predictive model is coming from, is how generalizable is it going to be to where you're trying to apply it. And a lot of times these models are still designed on very limited data sets. So we have to be careful in terms of considering generalizability. So in terms of policy implications, the challenge here is that the legal process is really not nimble, and we're seeing actually a lot of companies that AI development is quite rapid, that they are actually focusing on creating discussions of ethics as part of their process, because they recognize that self-regulation is better than oversight. In a lot of these situations, there is no policy in place.
Sorry, just...
Okay, yeah, when we talk about medicine, we still have to validate based on FDA approval. And that in itself may not be nimble enough for us to create new technologies as the technology is present. Thank you very much.
Thank you, and that concludes our session. Invite everyone to proceed to lunch. Thank you all. Thank you to all speakers.